Understanding and addressing individual and group behavior is essential in order for teams to meet their goals and serve their patients. The AHA's Physician Alliance has interviewed several clinician leaders to understand how hospital leaders can make medicine kinder, safer, and more reliable through promoting professionalism and accountability. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, Senior Writer for AHA. This episode is a conversation with Jay Bhatt, former Senior Vice President and Chief Medical Officer at the American Hospital Association, and Dr. Gerald Hickson, Joseph C. Ross Chair of Medical Education and Administration at Vanderbilt University Medical Center, and also Founding Director of the Center for Patient and Professional Advocacy.
So to get us started, Dr. Hickson, please tell me a little bit about yourself and your experience.
Well, Jay, I am a pediatrician by training, but I have also been a researcher, have been an administrator, have been someone who has spent really now 35 years focused on how we encourage medical team members to play well together. Jay, when we think about making medicine kinder and safer and more reliable, we need to have intentionally designed systems. That's a critical element for safety. But those systems have to be populated by professionals who are also willing to hold themselves and others to accountability toward those systems so that we can deliver the care that we all aspire to. So, Jay, it's an honor to be with you. Always honored to talk about how we work to make medicine kinder and safer.
Excellent. Thank you, Dr. Hickson. Now, the center has done incredible groundbreaking work in moving forward the notion of professionalism and high reliability. I've really enjoyed the opportunity to see that work evolve over the last several years, and we're grateful to be a part of it with you. But wanted to just focus in on an example of the work you've been able to see through the center.
Unfortunately, a lot of this work took off when we had a tragic event at an institution where I work at Vanderbilt. And we had a very thoughtful leader who brought a group of us together. We'd had an event in which a patient had suffered a bad outcome related to a medical error. The patient suffered, his family suffered, but we also noted that the staff that provided care and the clinician involved in the case also suffered in that circumstance. The challenge was, as our senior leader told us, we all saw this problem coming. The physician in question was internationally and nationally recognized, and yet everyone recognized that this individual was a challenge and at times seemed to be a problem waiting to happen. And a very thoughtful senior leader said, "Not again," and assembled a group of us who were interested in common things around human behavior and performance to come together and to begin to lay the foundation for the program that became the center at Vanderbilt as we work to understand the consequences of unprofessional behavior on outcomes of care, but more importantly, how we identify and share with colleagues early in a way that gives them an opportunity to self-reflect and be the professionals that they aspire to be. So, Jay, that's been a part of the work, and over the last 30 years now, we have shared with 2,000 plus clinicians, not only at Vanderbilt, but around the world, and it is amazing to see how many do well when fellow professionals simply have the training, courage, and data to sit down and share.
That's outstanding. Appreciate you sharing that. The second question I want to go to is about behavior. So how does unprofessional behavior affect hospital performance, and how can organizations promote accountability?
Jay, it's a very important question. We've always had this notion that my technical skills, my cognitive abilities are mostly sufficient, but they're not. Increasing research shows very clearly that medicine is and has always been a team sport. At a minimum, a partnership that needs to be effective between patient, family, and the clinician. But now, as we think about more complex care, all of the other individuals that are absolutely required to deliver high complex care. And we understand that the better they work together, the more likely they are to deliver the care they intend, and the more likely we are to protect against slips and lapses, those things that will, in fact, lead to errors and adverse outcomes. And so, Jay, it comes back to team performance. And we know that team members who feel respected perform better. They're more likely to speak up. They are more likely to ask for help when it's needed. And their situational awareness is better because they're paying attention to their job, their task. They're not paying attention to when I, as a physician, may walk in and treat them disrespectfully. So these things are critical. And the research that we've done, really beginning in the late 80s and early 90s, continue to reinforce the importance of respect and teamwork and how its absence creates bad outcomes for everybody involved.
So, Jerry, you made some wonderful references to the way unprofessional behavior can affect hospital performance. And I'd like for you to talk about that a bit more, because we see this impacting a set of different issues, from workforce to outcomes to medical malpractice and others. But what's your view on some of these sort of broader impacts on these other issues?
Jay, my insight in this area came as a researcher initially and more recently in our work to support other centers nationally who are seeking to create a reliable approach to deal with professional accountability. But what we know, our early studies were focused on why a very small subset of clinicians had more than their fair share of malpractice claims experience. In a study we did in the state of Florida, we did extensive reviews of obstetricians and their practices who never had a med-mal claim versus that 6% that had way more than their fair share. And patients told us what we needed to hear. We didn't find differences in the practices, their setup, the complexity of care that was delivered between those clinicians who never got sued and those who were sued regularly. But when we did ask families about their experiences, what they told us was that if I was seeing one of the clinicians with high claims experience, I couldn't get my questions answered. I couldn't get access to care, and I never felt respected as a human. When we have a bad outcome and we have bad pre-existing relationship between the clinician and the clinician's patients, it's common sense. More families will turn to an attorney and have questions that may lead to a malpractice claim. But that was early studies, and I want to call your attention to work that has been led by Bill Cooper, who now runs our center at Vanderbilt, because what we've done is looked at the concept now of respect and how that impacts the performance within the OR. And so we know that if you're a patient and you are going to see a surgeon who is not described by patients and families or by fellow staff members as disrespectful, versus seeing one who gets lots of those complaints about disrespect and unprofessional behavior, we find that if you see that high-risk clinician, you are much more likely to get surgical site infections, to have metabolic derangements, post-surgical procedures, and all the complications that are measured in the National Surgical Quality Indicator Project. So what we've learned is that that disrespect plays out basically in the OR, and we suspect in the ED and in the ICU, so that not only will disrespectful behavior get you sued, it increases the probability that your patients have bad outcomes. We also know that many nursing professionals who depart their institutions will say, we left because we just were not in a healthy workplace. And all of us know the cost of replacing nursing professionals. All of these things roll up to say there's a human cost for not dealing with unprofessional behavior. There is an economic cost related to med-mal claims, surgical site infections, and everything else that we measure. This is one of the reasons that we need to address the issue. The biggest issue is just because we're professionals, and that's what we commit to as professionals.
Thanks so much, Jerry. Those were excellent insights. What are essential things that have to be in place for accountability work to be effective and sustainable? Now, you talked about how organizations can promote accountability, but what do you got to have there so that it's in there for the long haul?
Jay, it's really important that when we think about promoting professional accountability, that we understand that it's not done on the basis of individual personal courage. It really requires a plan. And that plan has to be composed of people, process, and systems. And it really becomes a major part of who we are. And this is the issue of sustainability. So we've learned over the years that, gosh, you better have the right people in place. And so for any hospital, health system, no matter how small or large, they need to have an intentional plan. And it begins first by having the most senior leaders committed. Now, that commitment doesn't come easy. A hospital CEO is in a position at times where they have lots of what appear to be competing priorities. But to understand the issue of maximizing safety, high reliability, it simply means that leaders are individuals who say, we are going to develop those systems. We are going to identify best practices, but we're going to expect people to follow those best practices. Perfect example is the issue of whether or not we're going to wash our hands. As simple and trivial as that may be, it is not. But to ensure that people do that every time means that senior leadership has to declare this means everyone and no one is exempt from these expectations. And so we often talk about leaders that understand the impact of unprofessional behavior and leaders who are willing to say it applies to everyone and we don't blink. Now, another essential part of this, Jay, is that there needs to be somebody who really is the local champion. Now, that means local champions in nursing and pharmacy, among our physicians, because they all have to be actively involved. And these champions have got to be individuals that have enough tenacity to see this through. It is amazing to me at how often individuals see themselves as terminally unique and need to be reminded that, gosh, you do need to wash your hands. We do need to follow best surgical bundles. We do need to prescribe antibiotics correctly. And they need feedback. And that champion has to be able to mobilize others to assist, to provide feedback, good data, and ensure the processes are in place that people are being treated fairly. And all of that has to be supported by a team. The people part of this, probably the single biggest element, but it is not sufficient unless those individuals also have processes in place which are defined by clear goals and values and policies and procedures that allow us to engage with each other early. One of the great problems that we see along many of the policies is that they define when we need to begin to consider limiting somebody's ability to practice. That's way too late. And those policies that we establish for support of professionalism must acknowledge that we need to have the informal cup of coffee conversation. We need to be able to ask people to begin to think about what others are observing way before it becomes a formal process. Those processes also have to be defined by a very defined tiered intervention strategy. And we have over the years developed and used our Vanderbilt Promoting Professionalism Pyramid, which is a way to help people understand how we engage with each other. The pyramid respects the fact that the vast majority of professionals are in fact professionals. In fact, we just need to provide regular feedback and honor them and praise them for who they are and their commitment to the patients they serve and to each other. All of us on occasion, because medicine is inherently stressful, may have a bad day, may stub our toe, and in that circumstance, we want to be sure, and the pyramid outlines the fact that we just want to provide feedback to single events by what we refer to as an informal conversation that we call a cup of coffee conversation. It's important just to share about an event to let you know, Jay, that there seems to have been, as we jokingly say, a disturbance in the force, and we trust you to reflect on the circumstance and do the right thing. We find that when you consider those who always do well, those who occasionally stub their toe, If we just provide that feedback, that is sufficient. Unfortunately, we've also learned over the years that just about 3% of our colleagues, and it doesn't matter what discipline you're in, whether you're a certified nurse midwife, an advanced practice professional, a pharmacist, a physician, or anything in between, about 3% of the group will model what appear to be patterns of unprofessional behavior. And if they're supported by leaders within the organization and good data, we know in those circumstances that if we send a peer, not a leader, but a peer messenger who's been trained, someone in the same discipline, to simply sit down and say, Jay, for some reason, you seem to be associated with more of these disturbances than others. I need you to reflect now on why this appears to be more common, but we trust you to figure out the why and to move forward. And the great news, Jay, that we know is that 80% of people who get such conversations, and remember that's 80% of 3%, they will respond. Now, that also implies the fact, as the pyramid defines, that there is a small subset of individuals, less than 0.5%, that will not respond, and therefore now it is time to become formal and directive about what the interventions. So I want to let you know, as we think about creating a sustainability program, you got to have that tiered intervention model, and then you obviously need the systems that collect the data that will be distributed, that will look at individuals compared to all within the group, and appropriately train messengers to sit down and, in the most effective, non-inflammatory way, share with their colleagues these opportunities to self-regulate. That's what we've learned, and that doesn't occur without strong leadership that is committed and will hold everyone accountable.
Now, you and Dr. Cooper have been at this work for quite some time and have gained experience nationally from different kinds of systems, different geographies. What are a couple key learnings and takeaways that you've had from this experience nationally?
You know, Jay, it's really amazing. As we started this work, late 80s, early 90s, it was the question about whether or not physicians, because that was the first group that participated at Vanderbilt, whether our physicians were unique or whether or not physicians in other parts of the country, small rural settings, essential access hospitals, large metropolitan areas, everything in between, whether they were similar or not. And one of the things that we've learned is that humans are humans. And whether they are in the Dakotas or in California, in New York or Tennessee, wherever they may be, we find exactly the same distribution of these disturbances. The vast majority of individuals are, in fact, professional. 3% will model patterns of behavior, and less than 0.5% will not respond to a peer intervention strategy. So the first and most important lesson is that even though we will want to believe that our circumstances, we are terminally unique, it's just not true. Critical lesson. The second thing is that people will respond. One of the things that one of our senior leaders was concerned about early in this work is that we would never get peers to sit down and share with each other. That has been a very important question that we now have answered. And the answer is that physicians who are not the chief medical officer or the chief of staff, who are not in a formal position, they will go share. If the organization has leaders that are really committed, they will be provided good data so that when I walk into your office, Jay, I really can assert that you have more of these disturbances than others. And then there has to be a commitment to teach them how not to fix their colleague. That's not their role. Their role is simply to share with them observations and ask the colleague to reflect. That's a powerful thing, and physicians will participate in that. And one of the most satisfying things of this work is how many individuals who were recipients will then join the peer messenger group and be very effective in the process.
Appreciate those insights, and I think I've seen systems really take those to heart and make significant progress using the tools and the fantastic team that you have in place at the center to help them along the way. So what advice would you give to those starting on this journey, Jerry?
Jay, it's important for those individuals who want to pursue a sustainable approach in promoting professional accountability. Got to recognize that physicians have got to be the leaders of this effort within the facility. They've got to be supported. There has to be an expectation that, in fact, they are willing to engage each other as my understanding of what it means to be a professional. That's a critical thing. It's also critical to understand that you've got to have partners. A chief of staff, a chief medical officer, they can't do this on their own. They have to be supported by other influential members of the medical staff who say, I will stand with you in support of this fair and predictable process. One of the smartest things that we ever did at Vanderbilt early on was to recruit 12 individuals who were seen as individuals that were respected by other clinicians and who had a willingness to sit down and share after being trained and would keep their mouth shut given how important confidentiality is in this process. Those things are really important. And finally, I would remind anybody starting down this pathway that it is a marathon, and you're talking about 3 to 5 years before you get to exhale. And I remember that very specifically here at this institution. This work now has become a part of who we are. But in that first 3 to 5 years, you were never completely certain. So I would tell those interested, persevere, meet regularly with leadership, have your partners to stand there and support you, and be willing to make a mistake or two along the way.
Dr. Hickson, really appreciate your insights, your contributions, and the leadership that you, Dr. Cooper, and the team have provided on moving our field to be kinder, safer, and more reliable through professionalism and accountability. Thanks so much for taking this time to be with us.
Jay, it was an honor. Thank you very much for your interest in this work as we work to make medicine kinder and safer.